Hello, everyone, and welcome to today's webcast from the Agency for Healthcare Research and Quality on patient safety in medical offices using SOPS tools to drive improvement. I'm Lisa Huddleston, the communications lead for the contract that supports AHRQ's SOPS surveys, and I'll be the moderator today. Next slide, please. Let's briefly go over a few housekeeping items. First, you can download a copy of today's slides on our event website at https://events.westat.com/SOPS. Second, if you're having any issues with sound coming from your computer audio, you can connect to the webinar audio using your phone by selecting the Call Me option to enter your phone number and receive a call from Teams, or you can click on the phone call to find the dial-in number and the meeting ID. If your computer freezes during the presentations, try logging out and logging back in. And at any point in today's webcast, you can ask a question through the Q&A icon and enter the question into the Q&A box. Once you type in your question, click on the Ask button, and your question will be submitted for answering. We encourage you to share your name and your organization and your role when you type your question, and the speakers will respond to your questions during the Q&A portion that will take place at the end of this webcast. Please note that the raise hand feature and chat function are disabled. If you are using a Mac and are unable to see the Q&A icon, check to make sure that you are accessing the webinar through the Microsoft Teams app instead of the browser. A replay of today's webcast and the slides will be made available soon on the AHRQ SOPS website. There's only one Teams link for the entirety of today's webcast. If you leave at any time, you can rejoin using the link provided in the email that you received after you registered. Next slide, please. Now I'm happy to introduce our speakers for today's webcast. First, we have Jonathan Backdash, who is a social science analyst for the Surveys on Patient Safety Culture, or the SOPS program at AHRQ. We also welcome Amelia Ross, the Manager of Quality and Health Equity at the University of Georgia Health Center. Finally, we have my colleague, Rose Tyler, who is a lead research associate for WESTAT, and she manages the SOPS surveys databases. And again, I'm Lisa Huddleston. I'll be moderating today's webcast. Next slide, please. Our agenda today starts with John Backdash, who will give a brief overview of the AHRQ SOPS program. Amelia will then discuss her use of the SOPS medical office survey and how the results helped to determine specific improvement opportunities. Finally, Rose will provide an overview of the SOPS databases and the advantages of submitting to the database and the steps for successful submission of survey data. Finally, we'll end with questions and answers. So let's begin, and I will hand it off to John. Next slide, please.
Thank you so much, Lisa. I am John Backdash. I'm going to tell you a little bit more about the Agency for Healthcare Research and Quality, AHRQ, give you a brief background on the Surveys on Patient Safety Culture SOPS program. Next slide, please. AHRQ is a research-based research and science-based agency. It's part of the U.S. Department of Health and Human Services. AHRQ is the lead federal agency responsible for improving the safety and quality of the U.S. healthcare system. What AHRQ AHRQ is not a regulatory agency. We encourage the use of our tools and products, but we do not require them. If there are requirements to use the Surveys on Patient Safety Culture, SOPS surveys, or other tools, they come from another organization or agency like from AHRQ. Next slide, please. And we really encourage voluntary submission of the SOPS database. So right now, the medical office SOPS database is open. And your data are protected from disclosure. So this is similar to certificate of confidentiality in research. So the use and access to the data is limited to only what is stated on the data use agreement you sign. This is all identifying information. Next slide, please. What is patient safety culture? The most succinct definition on this field of embodied substance, how we do things around here. Now, the more detailed definition is it can be defined as beliefs, values, and norms that are shared by healthcare providers and other staff in an organization. So these are the behaviors that get rewarded, supported, expected, and accepted as it pertains to patient safety. And the culture exists at multiple, patient safety culture exists at multiple levels, from frontline staff all the way up to the executives. Next slide, please. Here are some of the core areas that get assessed in the SOPS surveys. And these are kind of universal areas across different SOPS surveys. Like there's a hospital SOPS survey today, we're going to be focusing on medical office. So some of the key areas include communication about error, handouts and information exchange, staffing and workplace, and work pace and teamwork, for example. And now I'm going to hand it off to Amelia Ross. Thank you very much. Next slide, please.
All right. Hi, everyone. I'm Amelia Ross. I'm the Manager of Quality and Performance Excellence at the University of Georgia Health Center. Next slide, please. All right. Just to give you all some overview of where we are on in the country and kind of our organization and institution. The University of Georgia is the nation's first chartered university. We are in Athens, Georgia, about an hour east of Atlanta. We have around 43,000 students on our campus. The vast majority of those are undergraduates, that typical 18 to 23 age range. There are obviously outliers to that as well. And then we have 10,000 faculty and staff as well. So our health center services all of these people to some extent, as well as faculty, staff, dependents, and student dependents as well. We have about a little over 30 residence halls with 9,000 plus rooms in each of those. So they are kind of situated here on campus where we are definitely all the students' primary healthcare provider, but certainly those that live on campus. And then our Athens campus, our home campus, is just over 760 acres. Next slide, please. So the University Health Center, we have over 100,000 square feet of clinical space here at the health center. We have about 18 different departments, various specialties in our health center. So we have 4 primary care clinics, a gynecology clinic, an allergy travel clinic. We have a vision clinic, a dental clinic, physical therapy and massage therapy, as well as a full pharmacy, radiology and other diagnostic imaging. We have a full service laboratory that's CLIA certified, as well as a number of other, we have our counseling and psychiatric services department is here, as well as our Fontaine Center, which is our health prevention, education, health promotion arm of the health center that has a variety of subspecialties, including relationship and sexual violence prevention, nutrition education, wellness coaching, and a variety of other alcohol and other drug awareness, variety of subspecialties in that public health arm. The last fiscal year, which is a July 1st to June 30th year for us here in Georgia, we saw 22,000, just over 22,000 unique patients and clients during that time. And then we had just under 100,000 patient interactions. And we had, as you can see, 54,000 laboratory tests. We have around 300 employees. That number fluctuates. It always stays around the 300 mark. We are recently have our first school of medicine that is starting here, as well as we have just chartered a new school of nursing. So we are really focusing on increasing our student employment and becoming a place of teaching as well, research, and in addition to just providing great care. And so you see that number fluctuate some with the employees due to that. We have around 30 students last fiscal year, and then this year we're already around the 70 student mark for student employees. So we are definitely increasing our workforce that way, and you can see that in some of the surveys of who we survey. Next slide, please. All right, so kind of talking about how we apply the survey of patient safety here at the health center. We are a joint commission accredited institution. And so as part of those standards, we are required to survey our staff on their perception of culture and safety at least once every survey cycle, so once every 3 years. And we felt like the survey of patient safety from AHRQ is the best fit of all the ones that we looked at for our staff and kind of the assessments that we were looking to make improvement on. So we did our baseline survey, our first survey in 2021. And then we conducted our second survey in the fall of 2024. So we focused on perceptions of patient safety, staff training, departmental collaboration, leadership support, and interdepartmental communication. It is just a straight copy and paste of the SOPS survey that we use. We put it into Qualtrics to make it easy for our staff to respond, because that's what the university uses, but it's that same survey. And that way it also makes it easier when we look later and benchmarking and things like that. Again, we have around that 300 employees mark with full-time, part-time, PRN, and student staff represented inside of that. In our 2021 iteration of the survey, we had 136 responses, and in 2024, we had 177. We do not provide incentives for staff to take the survey other than letting them know that this is the best way that we can make improvements. And I think that there was the increase in that in the responses between the two surveys. I think them seeing changes being made from the first survey, they can see some actual changes that happened, some improvement. And so there was that kind of buy-in in that. We have staff newsletters that go out every so often. We promoted the survey that way. Our providers are given time to outside of patient care to complete the surveys, which helps with completion. In the past, we blocked them. Now we have a model where on Wednesday mornings they have administrative blocked time for either staff meetings or professional development, or for things like this, these different trainings and surveys that we ask our staff to complete. Next slide. So for the goal setting process, both years, when we completed the survey, we had our leadership team suggest interdisciplinary working group with representatives from all the major service lines, which in our case is administration, operations, medical services, our counseling and psychiatric services, combined with our health promotion department. They report to the same director, and our nursing services. So each we have representatives from each of those major service lines come together, look at the data, and tell us, what they, based off their experience in their units, and then also the data, what we should prioritize our improvement goals around. They reviewed the full data set and selected 6 improvement goals to be staggered over the 3 years in between surveys to avoid change fatigue and really have an opportunity for our leadership to practice change management principles as we were looking into these improvements. Interestingly, a lot of the priorities that were set were not our most negative metrics, but rather where they felt like we could have an outsized cultural benefit, like voice, psychological safety, and transparency. So this showed thoughtful engagement with the data and a desire for, meaningful long-term change and not just the quick wins. Next slide, please. So looking at our 2021 improvements, sorry, this slide's so busy, but I know you'll have a copy of it to refer to in the future. So recommendation was to consider staffing, making decisions regarding resource allocation in the best interest of patients to include sufficient staffing for our patient load. As if any of you know anything about college health, we have, like I mentioned, around 43,000 students and about 40-ish mental health providers. We are never ending the amount of mental health providers that we could add, and it would still be an enormous load for each of them. In the 2021 data, we saw, and this is not specific to mental health, but just in general, at our health center, 31% of our participants felt like the department had too many patients for the number of providers in their department. And then 29% disagreed or strongly disagreed with the statement, we have enough staff to handle our patient load. Going to jump down to the 2024 data where you saw that first number from 31% drop to 16%. So we were very satisfied with that improvement. We'll talk about the interventions and why that changed in a second. And then 20% disagreed or strongly disagreed that they had enough staff to handle the patient load, which dropped 9%. Part of the reasons for that is we did increase the number of mental health providers that we had available on staff. We increased our nurse visits to allow our nurses to practice at the full scope of their license. And we improved nurse triage. So we opened a nurse-run triage clinic. And then we opened up direct access to nurses through the patient portal, which helped with scheduling. It helped with those, we call them kind of nurse mama questions that we get a lot in the college health, of, should I come in, or really just triaging as well through that model. We also implemented in both our counseling and psychiatric services, as well as our primary care and gynecology clinics, an open access scheduling model. And so that reserves appointments that can be web booked until about 12 to 18 hours before those actual appointments, to kind of again open up that for acute needs there, that. And then that was more of our mental or our medical services. So our primary care and gynecology, we started that open access where we reserved those appointments from being booked, for well checks or other less acute visits in advance. Then we also opened what we call open access in our counseling and psychiatric services, where we hired those more mental health clinicians to provide care for a walk-in model, where we are open from 8 to 5, where students can walk in. We formerly had walk-in only for crisis. Now we are allowing any patients to walk in and receive therapy, in real time, which has tremendously helped the load for our mental health providers, where we have some mental health clinicians who just love, whatever walks through the door and it being different every hour. And then some that would rather see a schedule every day. And so it really meets, the way the clinicians where they would want to be, as well as our patient needs, because at this age, things can come up pretty immediately and they need help right now. So that has helped a lot. Next slide, please. All right. Another 2021 recommendation was to investigate the volume and nature of pharmacy inquiries. During our 2021 survey, 27% of participants report that the pharmacy calls the office to clarify prescriptions monthly, weekly, or daily, which is quite a lot. By 2024, that went down to 18%. And so that was a clear improvement. The interventions here is really interesting. What we found upon more investigation was that most of the calls were coming from our internal pharmacy, and the clarification was actually that our pharmacy had not received the prescription. So the students were getting down from our primary care clinics, either on the second floor or right nearby the pharmacy on the first floor. They were arriving at the pharmacy to fill prescriptions before they had actually been charted into the charts. And so most of those calls, or a lot of those calls, were around our internal pharmacy receiving the patients to pick up prescriptions before they were actually documented and sent over. So we have changed our workflow in response to that. We have asked providers not to discharge those patients from the clinic until the prescriptions were sent over to the pharmacy. So that had significant impact on reducing the amount of clarification and phone calls that we were receiving in the clinics. Next slide, please. And so the next recommendation from that 2021 survey was to continue to address the challenges of receiving information from external partners. 16% of our staff say they have difficulty obtaining records from other medical offices daily, weekly, or monthly. This went down to 4% in our 2024 survey. And historically, we are not anymore, but for a while there, we were a Joint Commission accredited primary care medical home. So we follow up on all referrals over and over and over. For any of you that are familiar with that process, we really take care of our referrals. And that record management. So looking at that, we wanted to see, where we could make improvements. One of the biggest changes we made is we obtained Epic logins for all of our nursing staff as opposed to just our clinic leadership, which is the EMR that's used for both of our local hospitals. And many of those referring providers that we refer to are owned by one of those two hospital systems. And so that really opened up access to getting those records in a much more timely manner. We also established a new position, a referral coordinator. We slash medical case manager position, who's a nurse here at the health center. And so she's been able, with that consistency to establish relationships with local practices. And that has improved the practice of getting those records tremendously, much more timely, having those contacts and being able to be, have a direct one-to-one relationship with those offices. Next slide, please. All right. So this recommendation was explore opportunities for and promote team building that lead to the establishment of a just culture where all individuals feel safe to voice issues of disagreement, concern, error, and safety. I'll go kind of quickly through these. Not a big change between these 2021 and 2024 surveys, unfortunately. 33% say it's difficult to voice disagreements sometimes, most of the time or always. That number went down to 31%, but again, kind of a negligible change. 79% agree or strongly agree that staff are encouraged to express alternative viewpoints. That number actually went up to 84%. 91% report that providers and staff talk openly about problems always, most of the time, or sometime. That number actually dropped to 87%, with a change from 9% saying providers and staff never talk openly, actually rose to 13%. So no improvement. In fact, some metrics were worse. And this is something that we continue to struggle with, and is still a focus of priorities for this next survey iteration in the 3 years before we launch this again in 2027. Is our priorities are around some of this. We have a QR code that we implemented actually out of my office, the quality improvement office, where it's an anonymous reporting code where you can bring up any issues or pain points or just really any ideas. It's kind of a catch-all that will be, taken anonymously and given to whoever is most appropriate in our executive leadership team for consideration and response. This is not super well utilized. There are a lot of different ways to report things in the organization already. We do sometimes get a lot of great ideas from this, but it hasn't been tremendously successful, but we are using it. Sometimes we get a lot of things like, I would love to have a pathway to the building so that we don't get rained on as we enter. Well, I would love that too, but I don't have the spare $2 million for that. And when I do, I would probably, if I ever were in charge, would probably invest it more in patient safety measures. But so not the most effective intervention, but we're still exploring more ways. We also have our employee enrichment ambassadors that host a lot of employee engagement activities, really have increased the number of those to kind of work on a cultural, cross-departmental communication, other events. But this is something we still struggle with, and it is going to be a focus of our next few years' work as well. Next slide, please. So highlights from the 2024 data, in patient safety, 80% of our staff rated the UHC as very good or excellent, which was a 5 percentage point improvement from the prior iteration of the survey. For training, 89% agree that staff received the on-the-job training that they need, with only 6% feeling untrained for tasks, showing progress in our workforce readiness. With teamwork, 88% agree that UHC emphasizes teamwork, which was up from 79%. So we're quite proud of all of those. Next slide, please. So strategic goals for the years upcoming before our next survey iteration in 2027. Our work group selected these 6 priorities to be focused on over the next 3 years, and set targets of movement that we would like to at least see this change in. So training with new processes, we'd like to see an increase in 3% of staff agreement that they are adequately trained. For organizational clarity, we would like to see a decrease of at least 3% in the perception of the University Health Center being disorganized. Again, around those cultural, psychological safety elements, we'd like to see a decrease of 3% in a hesitancy to voice disagreement. We would like to see a decrease of 3% in hesitancy to report mistakes. We would like to see a reduction of 3% in the belief that that leadership underinvests by being more transparent about our resources, and a decrease of 3% in the perception of too many patients per provider, so that perceived patient overload. Each goal includes at least one needs assessment to drive tailored solutions and measurable outcomes to track the progress. In such a large multidisciplinary organization like we recognize that while we're trying to move the total organization, we also want to take consideration into each individual department's culture, what's happening there, and see where we can learn and improve in all of those areas as well. Or take notes from them on departments that are doing really, really well, what maybe can be transferable to other specialties. So, we're doing needs assessments and say our laboratory, and if they're doing really well in certain elements, what are they doing that maybe could be implemented in our CAPS department or any of our departments like that. Next slide, please. One thing that I thought was important to note, especially for all of the administrators or quality improvement folks here on the call as well, is that sometimes, and in healthcare we know this, we have to deal with perception rather than reality, whether it's from our patients or our staff. And there is a learning lesson in that as well. So these key misconceptions from the survey or misperceptions disproven by operational data. We talked some about how our patients or our providers and staff feel that that there's an overload of patients. They also we had a slight decline in the perception that patients can get acute appointments quickly, went from 100% to 92%. However, this is not objectively the case in our data. We introduced that nurse-run triage clinic. We opened the open access scheduling, and that has objectively expanded that timely access to acute care needs. But this disconnect does highlight the importance of the internal messaging and transparency around the process innovation. So making sure that we are, telling our story, not just to our patients and our clients, but also to our staff, and letting them see the improvements that they have been part of and they have made. You can see in the data here to the right about our general medical services. We have our median appointment lead days. In 2022, we were at 2.32 days. And in 2024, that has reduced to 1.45 days. So almost an entire day reduction in those acute need appointments. With our percentage of appointments made in general medical services within 24 hours, we saw a reduction or an increase from about 37% of our appointments being made within the last 24 hours up to almost 50%. So again, a significant stride there where we really need to be more mindful of making sure our staff feel part of the changes, know the changes, and have kind of a touch on what the data is showing and not just those kind of anecdotal feelings about their work. Next slide, please. So opportunities for improvement, as we talked about, that respect and psychological safety, those cultural things that can be harder to move. While most staff do feel supported, 21% still find it sometimes difficult to voice disagreement. And 11% say it's always or most of the time difficult, which is unchanged since the last survey. So definitely something to focus on for our institution in the next 3 years before we do the survey again, if we expect to see any change. Patient load concerns. We did have a rise in staff who felt there were too many patients per provider. That went up from 15 to 18%. I'd like to do more digging. Is that because we're adding more students to the university, or is it about our feelings about it? There has been an increase of students enrolled at the university. Now, our utilization does not look tremendously different, but just kind of getting in and figuring out what that's about. Um, and then the next point, there was no change in the response. It was 20% both years, that there was not enough staff to handle the patient load. So kind of understanding that disconnect there. We also look at some departmental variance. Some departments showed relative declines in error prevention, change adoption, suggesting targeted coaching is needed. It says especially HR and operations, admin, HR and operations. That's where we saw the most variance, but there's variance through the departments. And I think, again, doing those needs assessment at the departmental level will really assist us in taking, kernels of greatness and also, some areas of focus inside of each of those that can be translatable or spend a little more time to focus on our interventions in certain areas, talking to the staff that are doing the work in those areas and finding out what their challenges are. Let's see, I did want to touch on kind of what, I think I'll do it on the next slide. Next slide, please. So limitations of the data. Yeah, I wanted to talk, and this is going to, I think, have a huge impact on some of the difficulty with our cultural changes, really seeing that just culture, moving those perceptions. So a big limitation is our ongoing departmental reorganization. So in the past 8 years, we have had 5 different executive directors. We several of those, a handful of those have been due to retirements. Employees who worked many, many years here were in that role and then retired either, after a long service. That's true also of our medical directors. We had a few medical directors who retired, and all in the midst of, the little thing called COVID. And so during this time, we've had significant changes. We've had 2 interim executive directors. So we've had a lot of reorganization. We've had some different leadership structures. We've had significant changes, again, in our, not just on the executive level, but we were reorganized in our branch department at the university. We were still under student affairs, but a new AVP was added over health and well-being. And so we are part of a well-being portfolio now. And these have ultimately been great changes and have provided us with more advocates on the university level, but also more resources as we have some non-clinical staff members out in the organization at the university at large who are helping, carry a lot of the well-being particular load. But these changes, these reorganizations are I think adding to the challenges that we have for the cultural change over a long term, that staff buy-in, as well as just some of the perceptions of disorganization that we had talked about, because things are changing so much, and in a time where healthcare is already kind of stretched thin. So just wanted to mention that there's kind of my thoughts about why that has been so challenging for us. But reorganizations are part of being in any industry, and so they are likely to continue. We're going to have staff who move on, or going to have staff who retire, and so how we react to those significant realignments, how we manage change, and staffing structures is going to be really important. But it is a limitation of this data, particularly as we drill down into the various departmental level data when we get down past the organization level. maybe, where physical therapy sat last 3 years ago is not where it sits now. And so is it really comparing apples to oranges to look at medical services that way, because it might have several new units inside of it. So that is something we also are going to consider as we continue to do this survey. Next slide, please. So in summary, we were pleased with our 2024 survey. It showed clear improvement in patient safety, staff training, leadership support, and cross-setting communication. We are pleased that the work group chose forward-thinking goals that emphasize culture building over quick fixes, and it can really help staff buy-in that's their colleagues making those decisions of what goals to prioritize. And so while we have challenges, especially around voice and workload and disorganization, the intentional and collaborative approach positions us well for sustained change, which is what we want to see as a long-term benefit. This survey really gives us great direction of where our staff's head and thoughts are, and then where we can best prioritize our approach to process improvement for the whole center. Next slide. I will turn it over to Rose.
Thank you, Amelia. It was really great hearing how UGA used the SOPS Medical Office Survey and the improvements in your organization. And if we could just move to the next slide. Great. My name is Rose Tyler, and now that you've heard about the SOPS Medical Office Survey and how results from the survey have been used, I'd like to take the time to discuss the SOPS databases as a resource for organizations utilizing the SOPS surveys. Next slide. As you may recall from John, the SOPS program includes surveys that healthcare organizations can use to assess provider and staff perceptions of patient safety culture, not only in medical offices, but hospitals, ambulatory surgery centers, nursing homes, and community pharmacies. For each of these surveys, AHRQ supports voluntary databases, hosting 2 a year, with the SOPS Medical Office Survey database currently open for data submission. Our latest databases have included 445 hospitals, 292 ambulatory surgery centers, and 107 nursing homes. Our 2023 medical office database included nearly 1,200 medical offices, and we're really hopeful to have more this year. Next slide. So participation in the databases is completely voluntary. So you may be wondering why your facility should submit data to a SOPS database. Well, participating facilities receive a free customized feedback report, which provides facility and database results, allowing for easy comparisons, and it may be used to identify strengths and areas for improvement. The feedback report even includes a summary that highlights survey items that did the best and the worst compared to the database. And if a healthcare system submits data for multiple facilities, they also receive an aggregated system feedback report, which averages their site's results. And then based on user feedback, this year we will also start providing facility results in an Excel file to better enable facilities to interact with the results and populate dashboards. This means you'll be able to sort, filter, format the data as you please. Additionally, AHRQ produces database reports that provide the aggregated results across all participating facilities. The report consists of a narrative description of the findings and presents data by various facility and respondent characteristics, such as geographic region and staff position. This report is publicly available to help further patient safety culture, research, and improvement efforts. Next slide. And here we have an example from the item comparative results section of our feedback reports, which displays item results from facility highest to lowest within the composite measure. So this example displays item results for the organizational learning composite, and then the database results and the percent difference are provided as well to allow for easier comparisons and identification of facility areas of strength and areas for improvement. Next slide. Okay. And because we are currently accepting SOPS medical office survey data, I wanted to discuss the medical office database, which is open until the 19th of this month for facilities that administered the survey between October 2023 and September 2025. Data will be accepted for the core medical office survey, the diagnostic safety items, and value and efficiency items. However, the supplemental items must have been administered with the SOPS medical office survey in order to be eligible for submission to the database. One thing to note is we recently updated our criteria on administering the supplemental items. So if you choose to administer supplemental items, you no longer have to administer the entire set with the core survey. And as always, you may choose to administer both sets of supplemental items, one set or neither. Now, we do have a few rules regarding the survey administration to be eligible to participate in the database, and this just helps to ensure that the differences in results are really due to differences in patient safety culture and not just due to having differences in the surveys. So, data will be accepted if survey item text and response options have not been altered. Survey items remain in their original order. Non-SOPS items are inserted at the end of the SOPS survey just before the background questions. And if you would like to ensure your survey would be accepted prior to survey administration or data submission, you may email it to us for review. Next slide. A few other things to note about the SOPS Medical Office database are that we require a minimum of 3 respondents for a site to be included in the database, but require a minimum of 5 respondents for a site to receive one of those individual feedback reports. And this is to help ensure that there is enough data to all the items to receive results. And for the database, a medical practice or health system may have multiple offices in different locations, but each unique location is considered a separate medical office when submitting that data. And additionally, if multiple medical offices are located in the same building, each office should be considered a separate medical office unless they share some or all administrative staff and/or clinical support staff. And this is really important that each office is considered separate because we do our analyses at the individual medical office level and not the respondent or health system level for the database. If it is determined that data for several offices were combined, the data may be removed from the database. But don't forget that we do provide system feedback reports, which aggregates results across all the sites in your system, so you'll still be able to get those results without having to submit your data as a single site. Next slide. Okay, and now speaking more generally about all of the SOPS databases, there are essentially 4 steps for data submission. First, enter or submit site information. Users can either enter in site details such as address and point of contact manually on the database portal for each site, or choose to upload a single Excel file with all those details for all sites based on our data specifications. So if you have data for more than a handful of sites, you might want to submit all the details in a single Excel file. Second, submit a questionnaire. Users submit their questionnaire for review to determine if it meets our criteria, and this may be emailed prior to data submission to our database technical assistance mailbox, which I'll provide details for on the next slide. But something that is new for this year's database is instead of waiting to submit remaining materials until the questionnaire is approved, users may continue to submit the rest of their materials required for submission. However, if the questionnaire is rejected after being reviewed, any data or information submitted will be rejected and removed from the database as well. Third step is signing and submitting a DUA. Users must sign and submit a data use agreement, which provides information on how data submitted to the database will be used and ensure confidentiality. This may also be submitted to the database opening or prior to the database opening by emailing our technical assistants. And then for the last step, submitting survey data, users will upload an Excel file containing their survey data based on data specifications, And the system will inform users of potential errors in the data file, such as missing columns and wrong variable names. So you're easily able to kind of correct those and resubmit. And then when submitting your survey data file, we just ask that you please double check that site IDs found in the survey data file align with site IDs from the site information file, as this is something we kind of commonly see in the database. And once everything has been successfully submitted and accepted, users receive an email just confirming that their data was accepted into the database. Next slide. We offer free technical assistance, or TA, to our SOPS survey users. Our general TA help desk can be reached at 1-888-324-9749 or via email at safetyculturesurveys@westat.com. And they can help you with questions about survey administration, such as making sure your SOPS survey aligns with the SOPS trademark and connect you with any of the survey materials or supporting resources. And international users can also request permission to use any of the SOPS surveys in their respective countries. Our database TA help desk can be reached at 1-888-324-9790 or databases on safety culture at westat.com. And they can assist with submitting to the various SOPS databases, answer questions about the database reports, respond to special analytic requests for data included in the database reports, and review questionnaires and DUAs. And I know it might be tempting to kind of send us all your data submission materials by email all at once, but we do ask that you refrain from sending us your site level or survey data files by email, as the database portal has extra protections to keep the data safe. We are happy to help, so please don't hesitate to reach out. Thank you for your time, and next slide.
Thank you, and thanks to John and Amelia and Rose for your insightful presentations. It is time for some questions and answers. Our speakers will be glad to field some questions, and I believe we do have a few that have come in. Next slide, please. Sorry. As a reminder, you may ask a question through the Q&A feature shown here. Look for the Q&A icon. We encourage you to share your name and or organization or role when you type your question. If you joined late, a replay of today's webcast will be made available on the AHRQ SOPS website. Also, if you are using a Mac computer, you may see the Q&A icon, or you may not see the Q&A icon. And if that's the case, you may want to try logging back into the meeting through the Teams application rather than through your browser. So let's get to the questions, everyone. Let's see here. I have a question for Rose. My organization uses the SOPS surveys, but we've never submitted our information to the SOPS database. Given the steps that need to be completed in the process, do I still have time to submit?
Yes, there is definitely still time to submit. Submission is open until the 19th, but we'll most likely extend the deadline. So if you would like to reach out to us at databases on safetyculture@westat.com, we'd be really happy to help assist with that and discuss further, provide you all the information and details that you need, such as specifications and whatnot.
Okay, great. Have one for Amelia here. How did you communicate the results when you did your baseline survey to the staff? And you did the baseline survey and got the results and analyzed them and determined your improvement opportunities. How did you communicate those results to the staff, and also the rationale for the changes that were going to be made with the improvement initiatives? Just wondering, was there any pushback, and if so, how did you address that?
Sure. As far as communication of the results, we use our e-board is what we call it, our newsletter, electronic newsletter to go to all the staff. So we would let them know, hey, here's the results, and this is what this interdisciplinary group does. However, we know that not everyone is as thorough with emails as we all would like to be. So we also post them. We have an intranet page, which is the starting page of everyone when they open a web browser, that we keep the results there. We also keep analytics on that to see, who's all engaging with it, to see, where there might be gaps of communication. We also distribute those to our what we call our leadership council. At the time is our middle management in the organization, and really spend time talking about it with that group. So the idea is to get into those different departments that way through their leadership, because what we know just from experience is that the closer the information is to them, so coming from their supervisors, it resonates a lot more than just in an email on an organizational level. So I think that really helps. And then going forward, I think an opportunity for us as well to do both the results and then also the interventions as they come through, is to use our employee enrichment ambassadors. They're kind of our cheerleaders for everything that we do, not just in culture, but around goal setting and organizational priorities, because there are members in theory from every department on that committee. And so to bring on a peer level back to those departments as well. For pushback, I think for some things, anytime, we're lucky to have people who have come into the organization and choose to stay for a very long time. College health is a great industry. Anytime you have change, I think that is going to have pushback to some extent. So there was some pushback initially with our open access model, how, this is a big change of scheduling, but then when they really saw how much they were able to see, the acute needs, or far less cancellations, or did not keep appointments on the schedule because they're, this population's very well. So, when they made those appointments 3 days ago, when they felt bad, by the time their appointment got here, they didn't feel bad anymore. So, I think it's just seeing those results come down. But communication, we've tried to attack it from a lot of different ways. But could always be better, and they'll tell us it could be better too. So,
right.
Yeah.
Okay. Sounds like you have a plan there, though. So, Rose, another one for you. Why doesn't the medical office survey? Why doesn't it have workplace safety questions?
So that's actually a really great question. And we've had several users express their interest in workplace safety items for the medical office survey. Great news is AHRQ is developing workplace safety items for medical offices, and we plan to pilot test that at the beginning of 2026. And we're really hopeful to release those results and the items later in the same year.
Okay. That's great. So just need to get some participants for the pilot testing, correct?
Yeah, we'll probably be posting stuff on there, so keep an eye out.
That's right. Another one for you, Amelia. Does being in that university setting, does it present any special challenges for maintaining that positive patient safety culture?
Yeah, I think, there's always unique challenges with anything. I think the university setting, we are a public university, and we're actually state employees. So we do always have to keep in mind that's very different for us than many of us who've worked in a hospital system in the past. We are subject to additional regulations. We also have accrediting bodies on the university side of things, as well as our own, quality and safety stuff. So keeping in mind where we fit into a higher ed setting, as a government employee setting, and then again as healthcare, is just, balancing all of those competing needs, all equally important. But sometimes it can be a challenge because you have many different goals in mind.
Right.
Yeah, I think, just that higher ed setting, definitely. And then another thing is, because we are so fortunate that many of our patient population, very much of it is young and well. We see a lot of, the same acute illnesses that it could be easy to become complacent. Our staff doesn't, but it could be,
Okay.
of
Right.
just we see a lot of the same things over and over. So that's where I think our health promotion, our health prevention area really shines. But we are typically, it's a blessing, but it's also, it could be a way that we could become a complacent if we're not always making sure to keep safety front of mind.
Right. Right. Sure. Just another question, Amelia, that I had jotted down. You had talked about the team building and just culture and not having improvement on that. Was that something that surprised you at all?
Um, no, not terribly. I'm coming
Okay.
up on my 10th year or just over my 10th year here, but I would say that just because of the administrative turnover, and just getting new leadership so many times. And then the pandemic, too, especially, we were lucky enough to be a vaccination site. And we did mass, testing, both symptomatic and asymptomatic for the university system that we really, uh, our work, we've been changing so much what day to day looks like over the past couple of years that I think that
Mm-hmm.
change fatigue can really wear on a culture. We had a lot of buyouts of people who chose to retire during the pandemic who had been most of their
Mm-hmm.
career here. So just a lot of change. I think the change fatigue probably is what you see showing up a lot in that culture.
Right.
But it's something that we're working on.
Yeah.
So
Yeah. Absolutely. Yeah. It's a process, isn't it? Just
abs
what they say, a journey, not a sprint, right?
Well, and it's a lot easier to fix something like, you're discharging a patient before the prescription gets down there than it is to like say, you can trust me.
Right.
Right. I mean, so that's
Exactly.
one is a lot quicker fix than the other, but we'll get there.
Right.
Sometimes they just take time.
Absolutely. Absolutely. We're just, I think we have time for one more question. Rose, I've got a question for you. Um, there is a question about um, how long, if you submit to the database, um, they want to know how long will it take to get their individualized feedback report?
It does take about 3 months once we've closed data submission, and that's just to kind of give us time to clean, analyze the data, reach out to organizations if we need to clarify anything, um, and then produce your reports, review them, and we'll get individual in a system report.
Okay. And just one extra one, as far as we know that the surveys are tools in themselves, but we do have a question about SOPS resources and if there are any other resources or tools available that can be of assistance.
Oh, yes, definitely. We have quite a few tools. And you can always reach out to the safety culture surveys at westat.com for more information, and they can give you all those resources. But we have a survey users guide, which is really great for getting started with the SOP surveys. We have improvement resource lists, which provide free resources that any organization can use. We
Huh?
have a resource list. Sorry, so we have like a free resource list if you're trying to find like resources to improve anything
Hmm.
from your survey. So it's like an order of composite measures and whatnot. And then we also have an action planning tool to assist organizations with creating an action plan. And we have technical assistance and we have webcasts such as this one.
Right,
A
absolutely.
lot, yeah.
And the webcaster is quite valuable, I'm
Yes.
sure. So lots of good, rich information there. So, all right. Well, we are about at the top of the hour. Just a couple more things. We periodically send email announcements through our SOPS email updates. That's to notify users about the various SOPS happenings, such as the webcasts, data submission timelines, and other survey development activities. You can sign up for these email updates by going to the top right corner of the AHRQ website and choosing the email updates associated with the surveys on patient safety culture. Next slide, please. So thank you to everyone attending today. We really appreciate it. And also to our speakers. Thanks so much for your presentations. After the webcast ends, you're going to receive an email containing a brief webcast evaluation. Take a moment to provide us with that feedback, as it really does help us improve our offerings and plan for future events that can better meet your needs. So yeah, please take a couple of minutes to do that. Thanks again to everyone for joining us. This concludes today's presentation. Have a wonderful day.